students, I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. This lecture is a part of my central nervous system series titled as Spinal Cord, Unconscious Proprioception and Related Spinal Cord Lesions. So there are a lot of lectures put up here when I say title because VB Anatomy has come up with 13 to 14 spinal cord related lectures, all of which you must see to really understand the spinal cord. Especially once you've done studying, please solve MCQs in the MCQ anatomy series so that you really understand whether you have understood. Most of these MCQs are based on PG entrance and do please watch them and learn, of course. The link for all these other lectures are given in the description section. Let's begin today's lecture, Spinal Cord Anatomy, Unconscious Proprioception and Related Spinal Cord Lesions. Students, we are essentially talking about spino-cerebellar, unconscious proprioception, spino-cerebellar tracts. Okay. So understand that from the body, there is information being carried up to the cerebral cortex through ascending tracts. If that information comes from surface, it's exteroceptive. If it comes from within the body, it is proprioceptive. These are some of the tracts, ascending tracts: fasciculus, gracilis, cuneatus, anterior posterior spinocerebellar, lateral anterior spinothalamic, spinotectal, and so on. You must be thinking, ma'am, there are many more. You've not labeled them all. Yes, that's because I want you to know only these first and then study the rest later. These are the ones that you must know thoroughly well before you go on to the others. Out of these 7, I will be teaching the anterior and posterior spinocerebellar today. Students, whenever we discuss tracts, we always wonder what is a tract. Okay, remember, tract is a collection of axons which are all coming from cells which have a specific cell of origin. Idhar udhar se nahi, they're all coming from the same bundle of cells. They're all located in the same place in spinal cord. They're all carrying the same modality and they're all relaying in the same region in the higher center. If that is true, then you are a tract. Tract does not contain neurons. Tract is a collection of axons of neurons. Okay. Then we talk about what is first order neuron, second order neuron, third order neuron. All this I cannot teach you every time. The basic concepts. This is all covered in my lecture on pain, temperature, touch, pressure, pathway. If you want to know a little more, you can go there. Otherwise, the link for this is obviously given in the description section. Let's begin today's lecture on posterior spinocerebellar and anterior spinocerebellar. You will feel, ma'am, you've added to the tracts. Yes, I have added because they all function together, do the same function. Let's discuss unconscious proprioception. Right. So, body's ability to sense the position, movement, spatial orientation is happening without our taking a conscious effort for it. These sensations are all the time ascending up. According to these sensations, body is automatically balancing, coordinating, maintaining the posture and also maintaining muscle tone. Who is carrying all this sensation up so that the body can maintain balance? Okay. This is being carried from receptors in the various parts of the body through some specific ascending tracts. So, receptors in the muscles, in the joints are all the time picking up change and pressure in the muscle and joints, sending signals up through spinocerebellar tracts and relaying this information into the cerebellum. That is unconscious proprioception and we will be discussing that today. A few anatomical facts before that. The tracts are present here in the lateral funiculus. So, these are lateral funiculus based tracts. Point number 1. Point number 2 is inside the grey matter of spinal cord, there are 2 nuclei called nucleus dorsalis, also called Clarke's column. अब रुक जाओ, सो जाओ. This Clarke's column is present only from C8 to L2. It's not present above C8, it's not present below L2. Very important fact number 2. Fact number 3. There are receptors in muscles, tendons and joints which are all the time picking up on the situation, the tension in the muscle, the pressure, the contraction, everything, and all the time it is informing the brain about body's position. So, the 3 facts I want you to remember is that there are receptors in muscles, joints, tendons. 2. There is nucleus in the spinal cord called Clarke's column which extends only from C8 to L2. And 3. Anterior and posterior spinocerebellar tracts are in the lateral funiculus and spinal cord. Okay. Using these material, we are going to carry out unconscious proprioception. Let's understand how. So, first I want to discuss posterior spinocerebellar and cuneo-cerebellar. 2. Chalo. So, some receptor in muscle, joint has started to pick up a signal and sends it into the spinal cord to the neuron lying in the dorsal root ganglion. Okay, you can see it here. This neuron carries the sensation inside, relays it, it's the first order neuron. It relays it into the Clarke's column at between C8 and L2. Okay, and so muscle joint sense sensation was picked up by the neuron lying in the dorsal root ganglion. It was carried inside. It was relayed into the Clarke's column. This was the first order neuron, and now at the level of Clarke's column its job is over. So, Clarke's column existing from C8 to L2 is receiving this information from the receptors of muscles, joints and tendons. But my mind is asking me a question. Ma'am, you said only from C8 to L2. So, if there is some sensation coming from below L2, where will it go? Clarke's column is not there. Yes? If it's coming from above C8, Clarke's column is not there. So, where will that neuron go and relay into? So, understand that it will temporarily stay in the posterior funiculus. At a lower level, it stays in fasciculus gracilis. At a higher level, it stays in fasciculus cuneatus. From gracilis, when it reaches higher at the level of L2, it finds Clarke's column and it comes into the Clarke's column. Okay. Now, I want you to think of this like you are staying in a small town in India. Okay. And you want to travel from Mumbai to New Delhi. Okay. Suppose you are staying in a place called Bharamati. So, what do? You travel by a small vehicle from Bharamati to Mumbai, right? And from Mumbai, you catch the main flight which goes to New Delhi. So, this is exactly what these tracts are doing. When the sensation comes from below L2, that sensation travels for a short while in fasciculus gracilis. It reaches L2. At L2, it finds, okay, my Clarke's column is now available. So, it quickly comes into the Clarke's column and begins to travel upwards after relaying. So, this is all the time. Give yourself some simple examples. It helps you. Okay. So, we've understood that the sensation has relayed in Clarke's column. If it was below Clarke's column, it travelled in fasciculus gracilis and at the level of L2 relayed into the Clarke's column. Now what happens? The second order neurons in the Clarke's column, they give out axons which travel into the ipsilateral posterior lateral funiculus and ascend upwards as the posterior spinocerebellar tract. Take a look. Axons from here travelled into the ipsilateral lateral funiculus began to ascend upwards as the posterior spinocerebellar tract. Remember the word ipsilateral. They never crossed over. Okay. Note. This sensation is coming from lower limb and lower half of the body. Okay. So, let's learn a little bit about posterior spinocerebellar, then we'll answer your question, what about upper limb? Let's do this. Posterior spinocerebellar is a tract formed by axons of second order neurons from the Clarke's column. So, Clarke's column was here, its axons cross over and form the posterior, come to the lateral funiculus and form the posterior spinocerebellar tract, such that the tract is located close to the surface. Posterior to anterior spinocerebellar, superficial to lateral corticospinal. It is not present below level of L2. Okay, this is important because below level of L2, therefore the lateral corticospinal tract becomes very superficial and can be damaged easily here. What modalities does the posterior spinocerebellar carry? It carries sensation, like I told you, from lower half of the body and lower limb. Again you will ask me, ma'am, what about upper half of the body? I'll tell you what happens. Remember, posterior spinocerebellar is responsible for coordination with cerebellum, for fine coordination of individual muscles, not the whole limb, individual muscles. Okay. So, lower limb, lower half of the body has ascended into the, has relayed in Clarke's column and has started up as posterior spinocerebellar. Who carries same for the upper limb and upper half of the body? The answer is cuneo-cerebellar tract. Let's take a look. How does it function? Again, receptors in the body have picked up some sensation from upper limb and upper half of the body. Carried it inside. They go to Clarke's column and they find, oh God, it is not there. What happened? There is no Clarke's column here. Where do we go now? Okay. So, what they do actually is they go inside and they enter into the fasciculus cuneatus, laterally situated dorsal column tract. Here they travel up to medulla oblongata. Okay. So, दूसरी वाली train from Baramati, you are travelling from Baramati to Mumbai by some other vehicle. Then you are waiting for that point where you find a flight which is going from Mumbai to New Delhi, right? So, it reaches medulla oblongata and here it finds a flight which is going to cerebellum. Who is that nucleus? Accessory cuneate nucleus. So, they go and relay into the accessory cuneate nucleus, which represents the Clarke's column at the level of medulla. Till now we were talking about the first order neuron only. There was no relay there, right? Here now the second order neuron will begin from accessory cuneate nucleus, ascend to the cerebellum as cuneo-cerebellar tract. These fibers are also called posterior external arcuate fibers. Question: what are internal arcuate fibers? What are anterior external arcuate fibers? All this comes in MCQ. You want to learn more? You can attend my MCQ class on spinal cord or study in any other way, but you must study this. Right. So, now let's summarize this. Okay, there is a posterior spinocerebellar, there is a cuneo-cerebellar. Both are carrying sensations from the body up. Posterior spinocerebellar from lower limb and lower half of the body. Cuneo-cerebellar from upper limb and upper half of the body. Both are responsible for fine coordination of individual muscles of the body in coordination with cerebellum. Both will relay into cerebellum to bring about fine coordination of individual muscles of the body. Okay. So, that is posterior and cuneo-cerebellar tracts. How do they enter cerebellum? Ma'am, you have just taken us till medulla. They have not reached cerebellum. No, they have not. How can they connect? How do you connect medulla to cerebellum? Through inferior cerebellar peduncle, right? So, these fibers also travel through this same inferior cerebellar peduncle. Take a look. This is posterior spinocerebellar tract. It reaches ipsilateral cerebellum. This is accessory cuneate nucleus, cuneo-cerebellar tract. It also reaches ipsilateral cerebellum. Both of them travel through inferior cerebellar peduncle. Pause, take a screenshot of this image. It gives you both the tracts in the same image. Okay, one carrying sensation from lower half of the body, other carrying sensation from upper half of the body. One relaying in Clarke's column, other relaying in accessory cuneate nucleus. Did these fibers ever cross, by the way? Did they cross? No, did it? Why didn't they cross? Ma'am, other lectures the fibers are always crossing. Descending fibers are crossing, posterior spinocerebellar, posterior column fibers are crossing. Why is this one not crossing? It's not crossing because cerebellum takes care of its own side. Cortex takes care of its opposite side. So my cerebellum wants to take care of the same side. So why would the fibers cross? They have to relay in same side cerebellum. Even if they cross, they will have to cross back. Okay? These are simple rules which help you when you are understanding tracts. Okay? So, the sensation was coming from receptors relaying in the same first order neuron, dorsal root ganglion. That doesn't change. If the sensation was coming from lower half of the body, it relays in Clarke's column. If it's coming from upper half of the body, it relays in accessory cuneate nucleus in medulla. They travel upwards through the inferior cerebellar peduncle and relay in the ipsilateral cerebellum. First order neuron, second order neuron concept should be clear. It is a tract to cerebellum, therefore you find only two order neurons. What about anterior spinocerebellar and what is rostral spinocerebellar tract? Let's understand that. So again, anterior spinocerebellar is also receiving sensations from receptors lying in muscle, spindle, tendons and joints. These receptors relay these sensations into the first order neuron, which again lies in the dorsal root ganglion, just like posterior spinocerebellum. These fibers also relay into the Clarke's column, which acts as the second order neuron. But now what happens? The fibers cross to the opposite side. Are they supposed to cross? No. They are relaying in same side cerebellum, but they cross. So when they begin to cross, they form what is called anterior spinocerebellar on the contralateral side of spinal cord, not on the ipsilateral side. So this anterior spinocerebellar tract is located on the contralateral lateral funiculus, anterior to the posterior spinocerebellar. You can see it here now. The receptor has set off some sensation, which is picked up by the first order neuron in the dorsal root ganglion, relayed into the Clarke's column at the level of C8 to L2. The fibers now cross over to the opposite side, this is a second order neuron by the way, and begin to ascend upwards towards the medulla oblongata and brainstem. Okay, so this is your anterior spinocerebellar tract. They ascend to medulla, they ascend to pons, they ascend to midbrain. They just keep on rising up. But what happens? At the level of midbrain, they find the superior cerebellar peduncle. This is a tract which is crossing midline and going into the opposite side cerebellum. So, अपनी side को जाने वाला इन्हें गाड़ी मिल गया. So, what do? They go back to ipsilateral cerebellum. Best understood with an image. I can keep on talking, but you can see it to understand much faster. So, idhar tak we had brought our anterior spinocerebellar tract. It begins to ascend through medulla pons midbrain and then crosses through the superior cerebellar peduncle onto the opposite side cerebellum, therefore relaying in the ipsilateral cerebellum. A tract that started on left side relayed on the left side cerebellum after taking a long journey. In Marathi we have a very nice saying, kana magcha ghas. You can eat directly like this, or you can go around your neck and eat from the other side, isn't it? That is what anterior spinocerebellar tract is doing. But it still goes and relays into the ipsilateral cerebellum. It is believed that it does that. Okay. What is rostral spinocerebellar tract then? Students, just like we saw in posterior and in cuneo-cerebellar, anterior spinocerebellar relays sensations from lower half of the body. Rostral spinocerebellar, which lies very close to anterior spinocerebellar, carries the same sensations for upper half of the body. What function do these do? They are also getting sensations from the same muscles, joints and tendons. Then what is different about their action? So what happens is that they coordinate with cerebellum for maintaining the general status of posture and movements of entire body parts. Remember, that was individual body muscles. Here it's entire body part. Okay. So that is the difference in functioning of these two groups of spinocerebellar tracts. So we have got 4 tracts: posterior spinocerebellar, cuneo-cerebellar, anterior spinocerebellar, rostral spinocerebellar. Clear? Posterior and cuneo are functioning in coordination with cerebellum for fine coordination of individual muscles. Anterior and rostral are in coordination with cerebellum, responsible for maintaining of general status of posture and movements of entire body parts. Okay, not individual muscles. So this in one sheet or in one screen gives you the functioning of all the 4 tracts. So what happens if there is a lesion of these tracts? Okay, take a break, drink some water or maybe coffee. Think, if spinocerebellar tracts are damaged, what will happen? Remember, isolated lesions of spinocerebellar tracts are not common at all. Why? Because spinal cord pathways are so closely packed together. How tiny is your spinal cord? So it's not possible to just go and just spinocerebellar lesion. Not happening. Okay. So there will be associated lesions. It is something that is commonly affected in Friedreich's ataxia, subacute combined degeneration, vitamin B12 deficiency, tabes dorsalis, and vitamin E deficiency. Tabes dorsalis I have covered in my lecture on dorsal column pathways. Okay, do please go and study that. But the symptoms of spinocerebellar tract lesions are, there is loss of unconscious proprioception. So what the patient has is ataxia, imbalance while carrying out any movement. Patient is unable to smoothly perform any movement which requires muscle coordination. There is always imbalance in smooth movements. Patient has a very unsteady gait and very great difficulty in balancing and coordinating his movements. And this is not helped by vision. Okay, he cannot see and help himself. He is still unsteady. Okay, so this is a spinocerebellar tract lesion, not seen in isolation. Usually there will be associated lesions. More about these lesions, a lot more, is covered in my lectures on spinal cord lesions. Do attend that to understand better. So these are all the lectures I am taking on spinal cord. Gross anatomy of spinal cord, ascending tracts, which is the 5th one we've just covered today. Descending tracts. In all of these I am taking spinal cord lesions. Blood supply and one lecture entirely on spinal cord and lesions. And finally, do please attend my lecture series on MCQs of spinal cord, where I take PG entrance MCQs for you to help you to cope with your PG entrance examinations. Link for all these lectures is given in the description section. So students, this ends my class on spinocerebellar tracts. If you're liking my lectures, do like and subscribe to my channel, and please write some comments so that I'll understand whether my lectures are really helping you or not. What else can I do to make your journey in medicine easier? Please let me know. Okay. Thank you. I love taking this class. I hope you enjoyed it too. Bye.